Welcome everyone to Help is Here, a virtual conference series providing information and resources to families and caregivers about youth substance use, brought to you by the Connecticut Department of Children and Families and the Connecticut Women's Consortium with federal funding support from SAMHSA and CSAT. Without further ado, I'm pleased to introduce to you today's speaker, Elizabeth Kanata. Elizabeth is a licensed psychologist and is Vice President of Community-Based Family Services and Practice Innovation at Wheeler Clinic. She has over 30 years of experience delivering, developing, and overseeing behavioral health services for children, adolescents, and families across the service continuum. Dr. Kanata is knowledgeable about the array of evidence-based treatments that are available across Connecticut to address adolescent substance misuse and other behavioral health concerns. Thank you for being here with us, Elizabeth, and I will turn it over to you now.
The presentation that I'm going to be making this evening is part of a larger presentation that was developed through funding from the Connecticut Department of Children and Families through a SAMHSA grant that they have to improve the treatment system for adolescents with substance use disorders. And the training is part of a larger training to help families and those who refer families to understand more about what we call the alphabet soup, because there's so many initials and acronyms, MST, MDFT, FFT. And so the idea of this training was to provide information to families and to those who refer families about what some of these models are that have a very strong research basis of support, and to give an idea to families about what they could expect if they were to have one of these services provided in their home. So all of the models that I'll be presenting this evening are models that have a very strong research basis of support, that have, in the particular context this evening, that have been demonstrated to be effective in addressing adolescent substance misuse, as well as other behavioral and emotional challenges. The objectives of the presentation this evening are to give you an introduction of the research-supported models that we have in Connecticut so that you know a little bit more about what these initials stand for, what each model will look like if you were to have it or you were to help a family get connected, and what the underlying principles are that really are shared across each of these programs, because each of these programs was really developed and based on what we know about adolescent substance use and what we know about what can be helpful in really impacting and changing adolescent behavior. And so the idea is that as you watch this presentation, that you'll have more of a sense of what it would look like, and then in that way, if a family were to receive these services knowing what to expect, it really holds providers accountable for for delivering the services the way that they were intended to be delivered. Because what we know is these are models that have a strong research basis of support, that they work. The important piece is that they're being delivered in the way that they've been shown to be effective. And so I'm going to talk about that a little bit. We talk about that as treatment fidelity to the model. And so if a family comes in knowing what to expect, in a way, providers really are even more accountable to delivering the service in the way it's intended. So that's part of the intention of this training as well. We also want, in developing this training, the idea was to give you some ideas about what families have told us is helpful in receiving these programs. Connecticut is really in some ways very lucky that we have a very robust system of evidence-based practices, and it really dates back to 2000. And in 2000 there was a study at the time looking at children's behavioral health and how were we spending the dollars that Connecticut spends on children's behavioral health. And at the time, most of the treatment dollars were being spent on a very small portion of the children in need, and a lot of the dollars were being spent on out-of-home care, residential placement, and hospitalization. And so from 2000, there really has been a very focused effort in Connecticut to develop our system so that we have a number of treatment options, so there's not a one-size-fits-all approach, a number of treatment options that can really help to keep kids in their own homes and in the community, because we know that the more we can help youth to be successful in the natural environment that they live in, then the more long-term outcomes that we're going to have. So as we've been developing the system, the driving principles have been to improve access to services for families, help identify treatment models that meet diverse needs in an effective way, and make sure that these are models that are really family focused, because we know that families are really key to change in working with adolescents. So as a result of this work, and the partners in that work are listed on the slide here. I mentioned the Connecticut Department of Children and Families that funds a number of grant programs that help facilitate access to families. We have Medicaid reimbursement for a number of the evidence-based treatments, the juvenile justice system through court support services, the behavioral health partnership are all partners in developing our system of care and improving the services that help kids keep in the community. The guiding principles of all of the models that I'm going to talk about tonight are also that the models are strength-based, knowing that we want to build upon what may be working for the family or for the youth, and then help build upon those strengths to increase strategies and increase positive outcomes. So you may have heard of EBPs or EBTs. What are evidence-based practices? Because that's really what all of the models I'm talking about tonight. And evidence-based practices or evidence-based treatment is a term that's reserved for treatment interventions that have met certain criteria. And the first criteria is that they are well defined in terms of who the target population is, who have the models been demonstrated to be effective with, if they've been demonstrated not to be effective with other populations. And that's an important part of clarifying the application of a particular treatment model. But there are also models that have well-defined practice parameters. We call that a treatment manual. So clinicians who are doing these models have been trained, and they've been guided and continue to receive support and ongoing consultation and supervision and coaching to make sure that they're following the practice parameters that are helpful to create the change that families are looking for. It also is important to understand that when we talk about training, we're also talking about ongoing coaching, because it's not enough to train clinicians one time and then expect that they continue to do that in an ongoing way. So there's a focus in all of these models in ongoing quality assurance to make sure that the treatments that are being offered are being delivered in a way that's most likely to be successful. When we talk about an evidence-based treatment, we're also talking about a treatment that's had a very rigorous research basis of support. And usually that's a type of research that shows that this is a treatment intervention that has been demonstrated to be effective compared to other treatments, compared to treatment as usual, and that they're called random control group design studies. And for those of you who may have studied statistics, the notion of a random control group study is that we're studying an intervention, and as clients come in, they're randomly assigned to our treatment or to treatment as usual as a way to make sure that we're not just saying, oh, this is effective because we tested it on a very narrow group of individuals. So usually these are studies that have a rigorous research design that helps to demonstrate that the model is really making a difference. It's not just random variables that are accounting for that. So when I talk about making sure that the models are being delivered with fidelity, each of these models has rigorous protocols that clinicians follow, some of them including that they get the model developers get feedback from families that their experience is consistent with the model. The idea is to prevent the therapists who are trained in the model begin to drift and do something else that maybe is not as effective, and that each of the models have specific tools that they're using for that. And I hope to talk about that as I go through, because I think part of a family being ready to have a service in their home, knowing why some of the tools that are used are being used, can be helpful just to understanding the background that really is part of the excellence of the service that you'd be receiving. But as I talk about clinicians following a model, something that I think is really important to emphasize is that these are not models that have a one-size-fits-all approach. Because you might be listening and thinking, oh, if my clinicians have to just follow the book, maybe they're not going to understand unique things about my family. Each of the models that I'm going to talk about really entails a comprehensive conversation with families to provide a really careful, multifaceted screening with the family to understand individualized factors that are going on. So family factors, understanding more about the family's community around them, who are the supports in the family, where are some of the challenges, understanding individual factors about the child, the peers that they're spending time with, what's happening at school, who are the supports that the family can pull in, what are some of the stressors. And each of the models looks at the presenting concerns that come into treatment to understand how those are being perhaps sustained, how they can be changed by looking at the situation in a very complex and individualized way. And the treatment plan that is developed in each of these models is highly individualized to that youth and that family. So this is part of the alphabet soup that we have in Connecticut. These are the models that are relevant to adolescent substance use, and I'm going to be talking about each of these. We have many more models that are treating other behavioral health concerns and other even family concerns where perhaps the parent is the focus of treatment. But the ones that you see on your screen are models that have target different types of behaviors, but substance use is one of the behaviors that has been demonstrated to be impacted positively with reduced substance use by the teen. Now, all of the models that I'm going to be talking about are either fully delivered in the home or they have an in-home component. And you might ask, well, what's the advantage of that? Or maybe it's really readily apparent. But you know, sometimes it's a challenge to get teenagers to come into a clinic. You know, a parent may see that this is headed in a really dangerous direction and they want to get their teen into treatment, and the teen is refusing to get into the car and go. Or, you know, there are other children in the home and it's really hard to get to treatment. You're working, you're juggling other child care concerns, and you got a teenager who doesn't really want to go anyway, and getting into a clinic can often be difficult. So one of the things that we know about trying to help families that are struggling with their teens is that if we can do that service in the home or provide some of the services in the home, sometimes that can help to get a family the help that they need in a way that is easier. And also it gives an opportunity to really, for us to get a sense of what's happening at home that you're struggling with that we might not see in the office of a center-based type of program. Generally, home-based services are intended to be flexible, delivered at times that are convenient for the family. Many of the models that I'm going to talk about are very intensive. We may be coming out multiple times a week. And so this is really something that is designed to give parents the help that they need and to give youth the support in a way that fits in with the schedule. We don't want to interrupt kids being in school. We don't want to interrupt the positive activities that they're involved in. And we understand that the family's already under a lot of stress, and so having that be at convenient times is important. We know that the benefit of treatment that's provided in the natural ecology surrounding the youth and family is that they're learning skills, and the family is learning skills, parents are learning skills to help the youth be successful in their own neighborhood, in their own school, in their own social context, rather than when kids are in a residential, very contained environment. They may do very well, but then they return home and they don't have the level of structure that has been helping. And so this is a way to really help parents to help the youth develop the structure that they need. So we also know that by being out and about in your natural ecology, sometimes our clinicians are able to identify resources that maybe the family didn't think of. That could be some neighbors. I mean, certainly we would never talk to a neighbor without a parent's permission, or we notice that there are other people that might be able to be helpful to the situation. We can go out to the school with you to talk to the school if that would be part of the intervention that would be helpful. We can look for other positive social activities. So being mobile gives clinicians an in-home treatment an opportunity to help you in ways that are different than clinic-based treatment or residential-based treatment. So I'm going to start with the first model, which is multidimensional family. This is not the first model in terms of in the history of in-home treatment. It's the first in my presentation tonight. Multidimensional family therapy. And I want to draw your attention to the web address on each of the slides, because each of these models with their strong research basis of support, have fantastic websites where you can get a lot of information about the model. You may even be able to see videos of clinicians who are doing the work or families talking about their experiences. You were sent the slides, so you have this information. You don't have to write it down. It's on the slides if you haven't had a chance to look at them yet. But I encourage you to go there for more information. I'll also share with you that if you go to the ct.gov/DCF, you can go to treatment options and you can find one-page information sheets on each of these models as well. So multidimensional family therapy is a model of treatment that was developed in Miami by Howard Little and colleagues, really with the intention of helping families who were struggling with their teens' substance misuse. And so it's a model that has developed particularly targeting adolescent substance misuse, but understanding that often teens who are using substances may also be involved in other negative behaviors or acting out behaviors. So often these are kids who are defying rules at home, may be truant from school. These are youth that have often very significant acting out behaviors in addition to their substance misuse. The model has been demonstrated to be effective in working with youth aged 9 to 18. Actually, we now go a little bit beyond because there's an adaptation of MDFT in Connecticut now with medically assisted treatment, and so we have extended the model beyond 18 for youth who are living at home and to provide that additional support. So it's a program that works intensively with the family, so this is intended for youth who are living in a home or family context, or who may be returning home if they've been in residential placement. They may be returning home because we would work with the family and with the youth for a month or so before the youth returns home, but we want to have 4 to 6 months of treatment while the youth is with their family. There can be other psychiatric issues and diagnoses, but substance misuse and disruptive behavior would be primary intervention needs that have been identified by the family. So MDFT, you can actually push it a couple of times so that there'll be 4 corners filled in, and we might as well just get it all up on the screen. Thank you. When the model developer, Howard Little, really talked about the 4 corners of adolescent substance use, and what we know from the research is that there are individual both strengths and vulnerabilities of the individual adolescent that can contribute to their substance use and their acting out behaviors. There are parenting variables that can help the youth get on track, and there may be parenting strategies that aren't working. There are family relationship issues that sometimes can be really drawn upon to help the youth be successful, and other times there are other family things going on that sometimes can get in the way of the family feeling as effective as they want to in helping the adolescent be successful. And I will say that if you're struggling with a teen who is misusing substances, has been acting out, often parents and families that come into our services are really feeling very tired, sort of disheartened that this is such a struggle, and even feeling hopeless. And so understanding that that's real and that is something that is understandable, but that's one of the things that needs to be addressed, because we know from the research that as much as teens look to their peers for influence, that parents can really make a difference in adolescents reducing their substance, eliminating their substance use. But we also need to understand that the broader context that the family is immersed in, so the extended family, the neighborhood, the community, are there pro-social activities? There are a lot of factors that families are dealing with that can be resources, and there are also things that can be challenges. And so we really look to understand all of these corners to assess both the strengths that we can draw on as well as the vulnerabilities that we have to overcome. When we think about the assessment in these 4 domains and understanding that behavior is complex and it's influenced by multiple factors, what we understand is that as complex as problems are, we need to understand that complexity and develop interventions that are going to be as complex as our assessment. So in addition to understanding the strengths and vulnerabilities in each of those domains, the MDFT therapist is looking to also develop interventions in each of those 4 corners. So if you were to receive multidimensional family therapy or refer a family for MDFT, then you would want the family to know that this is an intensive service program and that the youth have been showing difficulty in multiple contexts. And so the level of intervention is going to be very intensive. We want to provide a lot of guidance, a lot of support to the family, to the youth. And so typically that's happening about 3 times a week. That would be really the typical intervention. Could be, at times of crisis, it might be more than that. As things are stabilizing, it might be more like 2 sessions a week. But for the 4 to 6 months, you would expect to see your MDFT team about 3 times a week. And a typical intervention with MDFT would be a session with the parent alone, a session with the teen alone, and then bringing the family together, or the parents to, the parents, when I say the parent alone, it could be if both parents are involved, we would certainly have the parents together. The team that delivers the intervention is a therapist and a therapist assistant, usually a bachelor's level person. The two are working together to both provide the therapy offered by the therapist, but also to offer the family other supports. If there's a need to get information from the school, if there's a need to help identify recreational activities, or maybe the youth would benefit from being employed after school. The therapist assistant is there to really help the family and the youth access resources. The model includes drug testing, so when we go into the home, the clinicians bring rapid urine toxicology screening materials with them, and so we can do an on-the-spot drug test. And that's really for the purpose of working with the treatment. It's not for reporting to probation officers. It's not for reporting to other authorities that might be involved. It's really to inform the parents and the youth about, are we on track or are we struggling? And then what are we going to do about it? The MDFT team is available 24/7 to the family, so that we want to make sure that if you were to receive multidimensional family therapy, the model developers want to make sure that the response is not a local crisis team that doesn't necessarily know the particular treatment strategies that MDFT uses. So there's always an MDFT trained clinician available to respond to crisis. It wouldn't necessarily be your therapist. The therapists rotate on-call coverage, but there's always somebody who is trained in the model that is able to then offer you a response that is consistent with what you've been working on. So the core concepts here are to reduce the risk factors in each of the domains that I talked about, to build the protective factors, and understanding that the family is really the key to change for youth substance use and acting out behaviors. And so you'll often hear the MDFT therapists say that, parents are the medicine, and understand that parents may be tired and feeling hopeless. And so we really are going to work to increase your sense of urgency that there is something that needs to happen now, and that you can really make a difference, and the MDFT therapist is going to help you to get there. But we also, in MDFT, there's also an understanding that it can be helpful with the strategies that MDFT uses to help the teen think about what's in it for them. And, teens often feel like, oh, well, I was forced into therapy. And so by being able to help the teen think about, well, maybe there's something that would be worthwhile for me. Oh, my parents are so unreasonable. They just think, well, let's think about what it is you think should change, and what are you going to do to increase your parents feeling confident that you can handle that responsibility, for example. So there's a lot of research, as I said, and the research I want to highlight is that there has been a reduction, that lots of studies that MDFT has done to show that they are successful in reducing substance use and reducing arrests, reducing involvement with negative peers, which can be a really very high risk factor for adolescent substance use. Often they're using with peers. When you see the reduction of 41 to 66%, I really want to highlight that that is it seems like, well, there's a third of people are still using. Compared to other treatments, that's really a significant reduction. And we've seen that this model actually sustains gains well after treatment is over. So that's really thought to be connected to families having strategies for helping the adolescent be successful. There is an adaptation of MDFT that's been available for youth who are struggling with opioid addiction, which adds medically assisted treatment in addition to the wraparound family intervention, and also continues the recovery supports after the 6 months of treatment for another 6 months with in-home recovery supports to help the adolescent stay on track once the more intensive treatment is over. MST. Multisystemic therapy is a model that was developed for primary intervention for adolescents with significant acting out behaviors. Often they may be arrested, have had out-of-home placement, but substance misuse is one of the behaviors that we often see with adolescents who are acting out. And so this is a model that's been demonstrated to be effective in each of these domains. The model has been demonstrated to be effective with 12 to 18-year-olds. The exclusionary criteria would be a youth with autism, or if they needed immediate stabilization for suicidal, homicidal ideation behavior. And that would be true of MDFT as well. In MST, it's a similar group of kids that we're working with. It's a family intervention. It's very overlapping in terms of understanding all of the factors that are contributing to a particular teen's substance use and acting out behaviors, looking at individual factors, family factors. But the way that the MST therapists do it is through this fit circle and working with the family to understand all of the different things in each of these domains that contribute to each of the challenges, so that then we can help the family decide where to intervene first to have the most impact, and then what other factors we're going to help the family address to get the teen on track and staying on track. This model also 3 sessions a week for 3 to 5 months. Strong emphasis in MST on working with the families to create structure and support for the youth. And so in MDFT, I talked about the therapist is going to be working with the teen on what's in it for me, as well as working on the parents on how to create structure. In MST, the focus is more on helping the parents be successful with creating the structure, and for the parents to be the ones to really hold the youth accountable, even for the participation. So the therapist is going to work really intensively with the parent around how to increase their awareness of what's going on with the teen, how to set limits that are effective and be able to follow through, because we know that teens have lots of strategies to try to break down parents' resolve to keep up with the expectations. Helping the parents identify supports, and us helping to identify supports so that the parent is not doing this alone, but they have resources in their natural ecology that can help them stay the course for keeping the youth on track. In this model also, there's intensive wraparound support to help link families to the other resources that they may need, to make sure that the family has good connection with the school, to be working as a team to help keep the youth on track, because often these are youth who are acting out at school or having difficulties, and also to build the natural supports and the positive peer group connections that youth need to be successful. Also, all of the services in this model are provided by a therapist, master's level therapist, with a smaller caseload. It's a team of 1 that will be working with you. Also doing drug testing, rapid urine screens, to help monitor what's happening, and then make sure that there's follow through with the expectations, what the rewards are for youth doing, showing more responsibility comes with privileges. If they continue to use, then what are going to be the greater structure that the parent can create to help the youth be successful. And here too, 24/7 availability of an MST trained clinician should you run into difficulties. And a lot of the difficulties are predicted. The therapist is working with you multiple times a week, and we're really planning together what might be some of the challenges that will come along the week, and you have strategies for dealing with that, so that when the crisis comes, you know what to do. But if you need backup, or you just want to, sort of debrief afterwards, then there's always somebody available that's trained in the model. Here too, the concept of MST is that the youth is in, sort of a series of systems around them, multi-systems the youth finds himself in, hence the name, multi-systemic therapy. And so the youth is within a family structure, the family within the broader extended family, in the neighborhood, in the community. And then, of course, the provider agency, you know, the MST therapist and the team become part of the family system, working together to find the strengths that can be built on. Similarly to MFT, this is a strength-based approach on what can be built on. So interventions are uniquely identified in terms of the family's needs, and then they follow 9 principles of intervention, which include understanding the complexity of the problem and making sure that you're addressing that complexity, but making sure that it's through interventions that are really action-oriented in the here and now. What do you do when a particular challenge comes along? What can you anticipate? And then learning how to address, you know, where it doesn't work, you shape that. There's a real strong emphasis on helping the youth be successful in school, because we know that kids who are successful in school have better outcomes in terms of both their substance use and other acting out concerns. Getting kids involved in positive activities with peers who are not using substances and who are involved in pro-social activities is really a central focus of the MST therapist, working with the family, helping the parent identify and support the youth becoming involved with those resources. Extensive research. This is probably the most researched model at this point. In 2016, there were 55 studies. I think that we're close to 60 now. Over 43,000 families have received MST, and they followed youth as far as 22 years out, finding that not only were the reductions in the problem behaviors sustained, you know, 6 months after treatment, but even if they look at the individuals 22 years out, there's still a reduction in arrest rates. There's an improved family functioning, employment, and success. In comparison to treatment as usual, MST helps to reduce behavioral health and mental health problems, out-of-home placement for youth, reduction in risk of incarceration, reducing adolescent substance use, and high level of family satisfaction with services. We have a number of adaptations in Connecticut, and so these I'm only going to talk about briefly, because these are models that really probably the audience here may be less interested in terms of if you're referring families with an adolescent in the home. But MST for emerging adults is a model for young adults as they're really moving away from being in the home. Youth who have had a chronic mental health condition, who may have most typically have had some run-ins with the law. This is to help them stay successful. We know that substance misuse is a real high risk factor for youth making the transition, so that is addressed with the program. We also have a model called MST Family Integrated Transitions, and this is for youth who are returning home from residential placement because of court involvement. And it follows the MST model, but it also incorporates dialectical behavior therapy, which is a model that has been demonstrated to help adolescents who have impulse control issues and who have gotten themselves in trouble learn affect regulation and self-monitoring to make better choices. Functional family therapy, again, you see the website there. It's a model for families with a wide range of presenting concerns, including substance use, including other mental health diagnoses, acting out behaviors, or internalizing behaviors. It's a model that was designed to help also youth who wind up getting themselves into a lot of trouble through their behavior, and helping kids who are, you know, and part of that picture could be struggling with their own depression, anxiety, but often there is the acting out behaviors and the substance use that may be part of that. Again, this is a family intervention, really emphasizing that behavior. It's called functional family therapy because it recognizes that, as misguided and unhelpful as it may be that a teen is involved in substance use or the acting out behaviors, that often it is a misguided effort on the part of the teen to serve some positive function in the family. And so the functional family therapist will really help the family understand how this behavior may be making some effort on the part of of the youth to help the family make some positive changes. So this is a less intensive treatment. Rather than 3 times a week, a typical functional family therapy intervention is for families who maybe don't need as much wraparound crisis support, but really just need an intervention in the home that can really help address the tensions that have developed in the family, help the family understand the behaviors, how the parents can help the youth address the concerns in a different way. So it's typically a once a week type of therapy, maybe in the beginning 2 sessions a week, provided by a therapist. Really, this therapist is going to be very actively involved in helping the family think about the behavior differently so that they can address the behavior differently. So if you had FFT in your home, you would have a very active therapist who would be, interrupting things as they were going on, pointing out patterns of interaction in the family, helping you think about things in different ways, maybe even moving people around in the room. Really, again, focusing on strengths that they're noticing, teaching families new ways of communicating the messages that sometimes get lost in the tension around the behavior that's causing so much distress in the family. The FFT, functional family therapist, also is really helping the family think about, as they're changing those behaviors, what are the signs that they're going to look for in the future to know what they need to do to keep things on track. And that would be true of all the models I've talked about so far, is really focusing on helping families know what to look for in the future, because there will be challenges that come up. So we talk about sustainability and knowing that you have the skills to help your youth continue to be successful even after the treatment is over. Lots of research support for functional family therapy as well, showing reduction of illegal behavior, better completion rates of treatment. This is a model that has really excellent, as do the other models, because there's really a focus on helping the family feel heard, understanding, what's going on, working together to develop the treatment plans. And so there's good completion rates, improved family, relationships, and the reduced tension in the family, reducing adolescent substance use. The lower cost of the system is part of the research they've shown. These treatment models are more effective. That's not really about these are cheap treatment models. I want to emphasize that, because actually these models have quite a bit of grant funding to support the ongoing quality assurance and the training and the coaching and the ongoing supervision. But if you think about keeping kids out of jail and keeping kids on track and being successful in school and going on in a more successful way, the costs overall to a state, to a system, are significantly reduced. So that's not really about cutting treatment costs. That's more about doing better treatment. In the end, is less costly for the family and for the society. In Connecticut, it doesn't require that you've had delinquent behavior, although the model was originally developed to do better by kids who were getting themselves arrested. That's not a requirement of any of the treatment models in this program. Now, this model is adolescent community reinforcement approach, assertive continuing care, is actually not an in-home model. The blue, ACRA as we call it, is a clinic-based intervention. But it's included in this presentation because there is a home-based component, which is the ACC, the assertive continuing care, and that's why it got included here. ACRA ACC is a treatment specifically targeting adolescent substance use. And it's for youth who are not as highly and demonstrating as much external concerns to their families and to the community. So these are youth who may be having early signs of substance misuse, but not, have not yet been showing so much disruption at home, at school, in the community. So it's for less severe presenting difficulties, but the substance use is a central focus. And it's typically one time per week that the adolescent will come in, often with family sessions as well. And the focus is on training skills for the adolescent. And I'm going to talk about that in a moment, but I want to talk about the ACC part, which is in the in-home aftercare, which is to reinforce and strengthen the gains that are made during the clinic-based treatment. Because what we know is often after a client is discharged from treatment, that's a high recidivism, a high time of relapse possibility. So the model is designed to provide aftercare as a less intensive treatment, where a lot of that community networking and connection is happening in functional family therapy, MST and MDFT along the way. In ACRA, as the youth develop skills and the family develops skills for helping the youth be successful, then the in-home intervention helps to follow the youth afterwards. So it adds case management. And the assertive part is that the services are provided where the youth needs them to be. So if the youth is struggling with finding a job or is struggling in an after-school activity or in the school, that may be where the clinician works with the youth or with the family. So it's clinic-based. The ACRA part, individual, sometimes this can be done in group depending on the particular setting. Sometimes it's offered in a group context. If then the youth can be working together to learn the skills. If you're receiving ACRA ACC, there will be an expectation for family sessions, because we know for youth to be successful, the parents really need to understand how they can help the youth with that. And there will be some sessions working with you alone. Again, this is all coming from research that we know that adolescent substance use is really impacted by parents having strategies to deal with it. So you would have sessions with the therapist in the clinic as well. The focus is on increasing family, social, and educational supports and reinforcers for recovery. And during the treatment, the youth is learning skills to address the particular challenges that they have, whether those are refusal skills when they're with peers, they don't know how to say no. If that is, making better choices about what they're doing in their free time or who they're hanging out with. If their use is tied into coping challenges, then the therapist is working with them to develop skills so that they can more effectively address the contributing factors to their substance use. So typically, the skill will be practiced in the session, then the adolescent and maybe the parent has a homework assignment to try it out in the real world, and then when they come into the next session, how did that go, what worked, what didn't work, and then fine-tuning it from there. This model, community reinforcement, is a model that has been very effective with adult substance use as well. This particular model is specifically designed, though, for adolescents. So it's not an adult treatment model applied to adolescents, but these are looking at the developmental needs of teens and their substance use and the challenges that teens experience. So the home-based part, you would have at least 1 hour per week in the home, or it may be the therapist is working with the youth in the community. If there's need for more appointments, that could be set up. They're providing, the youth has recovery goals that they're looking to sustain after the ACRA treatment has been completed. The therapist will help to coach the youth similarly to as during treatment, where they learn strategies, they practice them in the sessions. Well, this is really practicing them in the real world, getting some feedback, getting some additional ideas, helping the youth to get connected to those pro-social positive peer groups and activities, positive sports activities or other after-school activities with non-substance using teens. And if there's a relapse, you have somebody right there who's going to help you brainstorm what happened and make sure that it doesn't get off track in the way it was before the treatment started. So making it work, when this presentation was developed, I really wanted to include, family input. So before I get to that, just the commonalities that all of these have a home-based component, if not fully in the home. They all are strength-based. They want to know what's working and how to build upon that. And as frustrated as you may be, they're going to help you find the strengths that you can draw from. Strong research basis of support, that clinicians are trained and receive ongoing supervision, so you're getting the quality of service that shows the effectiveness. And each of these models has stages of intervention, so you'll be working through a sequence of strategies and tools and interventions. But all of these models, as families will say, is as effective as the good collaboration that these models call for with the family, and that families working closely with the therapeutic team is really critical. So with the next slide, the family said to us, the way you help families is make sure that the treatment they're getting is matched to the needs that they have. So, you know, what was the model designed for? Make sure that that's what you're referring families to. If you are a family looking for treatment, think about what are the challenges that you have. How does that fit with the models that have been presented this evening? Are there criteria that would say this is not a good fit for you? So age, you know, if there's immediate risk of harm to self or others, that usually needs to be stabilized first for any of these treatments. Are there things that are going to get in the way of you being able to have the treatment? So maybe in-home treatment is a great thing, but maybe that's not something that's practical right now, you know, for your family for some reason. Then exploring that, but that matching the treatment to the needs that you have is really important. And you know, sometimes that's going to be influenced by there's not an opening right now. There may be two models that would be a really good match, and if right now there's a wait list, then maybe you want to get started with the other model because it's still a good match. So sometimes they may not be model specific as much as they are practical considerations. Also, depending where you live, which model has availability. Are there, you know, Spanish-speaking therapists, or if you have a different language need, that may be influencing. If there are two models that fit or three models that fit, that might influence what's the best match for you. The model provides the framework, but the work is really collaboratively and co-constructed with the family. So you can get what families said to us in developing this training, or said to me in developing this training, is it's really important that families give the model a chance, but that they also are, you know, upfront and vocal about what's working and what's not working, because it really is a teamwork. And all of these models would fully embrace that and say, yes, that's right on track. You know, you want to make sure that that when you're talking to the therapist, that they're understanding what is happening in your family, what is happening in your child's school. Those are important parts. And so that by the therapist being comprehensive and the family being upfront and direct about the information and what's working, what has worked before, what hasn't worked before, you're the expert on your child is the point. And so it's important that, and this is, you know, the feedback again that families said, is it's important for families to be honest about how they see it, ask questions, give feedback to the therapist, give input. Like, I don't think we could do that homework that you're asking us to do. That's okay, because it's not going to be effective to say, okay, you know, we're going to do something and it's not really practical, or it doesn't really make sense to you. That's something that's worth bringing up with your therapist. But the other thing that family said is that sometimes you're going to be asked to try things that don't really make sense. Give it a try, because the whole point here is maybe to do something differently than you've been doing. And sometimes that takes, you know, taking the plunge, the leap of faith. There's some strategy here that the therapist has in mind. So be open to being challenged. Now, it's important, no treatment is 100% effective. These are models that have extensive research basis of support, but it doesn't mean that it's going to work with every family. And so, you know, that's why Connecticut has really been interested in having a service array that has more than one treatment approach and more than one option for families. I've given you a slide with where the agencies are. Most of these models are available in a wide geographic spread in Connecticut. These are the agencies. It looks like the slide is cut off on the bottom. Hopefully on the one that you have in the handout, the ACRA ACC, there are another two agencies at the bottom. These are models that I think have helped families really build skills and build confidence in helping their teens. They've helped teens feel successful and on a more positive track that ultimately feels good to the teen. And so I encourage you, if this is what you're struggling with in your family, or if you're working with families, to consider referral to one of these programs that sounds like it may have the factors that will be helpful. So take care, be safe out there, hopefully continue to have power, and thank you for your time this evening.